Yes. This population's underserved because the system chooses not to serve them. That's something that therapists can help them with, is knowing how to safely return to exercise and how to be able to do just their minimum daily activity in ways that are safe and that protect their tissues that are vulnerable, like their pelvic floor or their C-section incision. I mean, there's so much that we could offer.
One of the questions that I probably get the most has been whether or not occupational and physical therapy is necessary, medically necessary after birth. And I really want to answer this question in a very graphic way. What's medically necessary? What's reasonably indicated during labor, during delivery, and during postpartum care? And I think if we frame it that way, then we can really kind of get into the meat of this discussion on whether or not occupational, physical therapy, um, just rehab interventions in general, whether or not those interventions are necessary or not. When it comes to rehab services, especially on the maternity unit in hospitals, is that our services as rehab professionals are unnecessary. Question is that true? Do we provide unnecessary services or not? And so, what I would like to do is explore this topic and let's go into labor and delivery, the environment, and really just have a discussion on what is actually done in that environment and whether or not we have a place or a role on that team. And so, Erin Locati, if you are in the room, go ahead and turn your camera on and just talk about the interventions that someone would normally see in the hospital after birth. When I think about the date of this article, one, we would not have been able to use this in our abstract because it's 2014. And I like to kind of just point that out is that one thing about evidence is that when you're given kind of a date restriction on whether evidence is 5 years old or 10 years old, and that's considered outdated, I want you to really consider that if we're doing the same things 10 years later, is the evidence really outdated? If we're doing the same things, getting the same results, is that evidence truly outdated? And so I proudly will use articles from 2014 or 2013 or 2012. I don't care because the articles that really have information that really tell us that what we're doing today is actually not working. We were doing better by following those recommendations back then. Those articles then are still valid. And so this was an article by Lothian, who really just like went through the common medical interventions that are used during labor and delivery and held nothing back. She went into why they were harmful and potentially led to more unnecessary surgeries during birth, like cesarean section. And so, with continuous electronic fetal monitoring, Dr. Licati, thank you for joining us.
I'm
I
here
kind
now.
Seriously, I was hyping you up a little bit because you just taught acute care OTs and PTs, intro to
Mhm.
rehab, basically intro to OT, PT and OT in the hospital after birth, and then high risk pregnancy interventions,
Mhm.
right? That rehab therapists could provide on the maternity unit, on the antepartum unit. And these questions come up, like are OT and PT services unnecessary? And so we're actually going to go through common labor and delivery interventions. And when I want to start with is continuous electronic fetal monitoring. In your opinion, or from what your knowledge is, why is this used continuously?
I mean, my understanding is the reason why it's used is to monitor the baby, specifically how their heart rate is doing, their heart rate pattern is, to hopefully catch any signs of a problem with the baby's heart rate, which can happen if there are issues coming up with labor or complications during the delivery. Um, so the idea would be that, well, if we're monitored the whole time, we reduce the chance that we miss something, right, that could adversely affect the baby. However, so I mean, on its face, I mean, all of these interventions, I think on their face, you can make an argument for why they might make sense. But for a lot of them, when studies are actually done on them, you find out that, oh, what we thought we were going to get from this is maybe not really what's happening in the real world. And that's something that I believe is true for continuous fetal monitoring, is that you end up seeing things on the monitor that could make the doctor think they need to proceed to higher levels of intervention, right? Like potentially even C-sections. But it turns out maybe they weren't really medically necessary to do them. And if you hadn't been monitoring, you just would have never known those things had happened on the continuous fetal monitoring, but everything still would have worked out. It's kind of like how we used to do. I mean, I think all PTs probably learned this in school, right? Where they used to do images of people with back pain and see things like degenerative changes and osteophytes and herniated discs and be like, oh my gosh, like that's not the perfect, anatomy textbook image of a spine. That must be what's causing your pain. Therefore, we need to do surgery to fix those things in your spine that we found on all this imaging we've done, right? And that will help you get not have pain. But then when we started doing studies, which totally makes sense, like that makes sense on its surface, right? You see all these gnarly things on someone's spine, that has to be why they have pain. But then when we start doing imaging of everybody's spine, including people with no pain, we're like, oh, turns out those gnarly things are totally normal. They happen even with people without pain, which means the serious intervention of surgery we were doing on people because of the findings on imaging were not necessary. That wasn't probably what was causing their pain. And I think continuous fetal monitoring is something that's similar, right? You see things on the monitor, you think that means there's a problem. Therefore, you implement a higher level intervention to address the problem you think is there. But maybe it wasn't really a problem. Maybe those are just normal anomalies you would see in any birth.
Dr. Locati, did you read this article?
No.
Just, I mean, honestly, like what you were describing, like she was going into, the author of this article, Dr. Lothian, was literally saying that you're going to be picking up signals that have been proven. Evidence-based research has proven that those signals would occur in other cases that are actually low risk or
Yeah.
not a concern at all. Like there will be decelerations with contractions. There will
Mm-hmm.
be, spikes in heart rate, with compression of the umbilical cord. When you have continuous electronic fetal monitoring, you're not able to move, typically. Like the
Yeah, they
nurse is
usually.
not like you're not just up and around walking, which is ideal for rotation for the baby to start progressing towards the canal. And so when you're still on your back or on your side, right, you're actually in a fixed position, which is actually more risk um, producing, in terms of like, the issues that can be caused. Um, and so electronic fetal monitoring should be, according to this article, replaced with intermittent, right? At
Mhm.
times, not continuously, auscultation with the stethoscope, which can actually pick up more concerning signs than an electronic fetal monitoring could, right? And that one blew my mind because I mean, it was right in line with what I thought that was a beautiful example, imaging, right?
Mhm.
Unnecessary imaging. We know that that is so true. I mean, I probably have several herniated discs, but yet I'm running and biking and doing a lot of different things. And so, do we need these kind of more invasive interventions? Intravenous fluids, why would that be used?
I think sometimes IV fluids are hooked up. I'm not 100%. For people if in case they end up needing to have surgery, right? They put in an IV access right away. Sometimes they'll tell you need to have IV fluids if you're getting an epidural. Um, but also you could drink fluids, right? But that's like the next one, right? The eating and drinking restrictions during labor.
Exactly.
This is super common, right? I mean, it's because there were just like anyone who's going for surgery of any kind, not just cesarean, would be told you're not supposed to eat or drink for so many hours before the surgery, right? You're supposed to be NPO because they're worried about a risk of aspiration during your surgery. Moms in labor get told that even at our very high C-section rate of 30%, 70% of them will not have C-sections. They're still, all of them are told to not eat or drink as if they were going to go into surgery. So they give you IV fluids because they're not letting you drink fluids through your mouth, which is, yeah.
She actually talked about interventions based on fear, and fear
There's a lot of fear
increases.
in hospital-based
Yes.
birth. It's very like modeled
Interventions,
around
yeah,
decrease. I mean, it's just like fall risk programs in hospitals, right? Like as therapists, we know laying your butt in bed for 24, 48 hours, especially if you're elderly, is detrimental to your health. But hospitals are so scared about falls that they sometimes overcompensate by like strapping everybody to a bed with an alarm. I feel like, I mean, the same mindset comes into labor and delivery even though most people don't need these interventions, right? They err on the side of let's treat everyone as if they could become the worst case scenario at any moment.
absolutely. How about Pitocin, artificial rupture of membranes? What are
So,
those fall into?
I mean, Pitocin will be used to induce labor, right? It's used to help mimic some of the normal hormones that your body releases when you go into labor on your
Mhm.
own. And artificial rupture of the membranes is kind of used for the same purpose, right? It's another way of trying to get labor going, right? Is when a doctor will literally like stick something, maybe their finger or an instrument, up your vagina, towards your uterus and go through your cervix into the uterus and puncture the amniotic sac, right? The baby's floating around in. And then all your amniotic fluid comes rushing out. So that would be the, like if your water broke. Normally, the doctor's just doing it for you,
Mhm.
hoping it'll kickstart labor.
Is there ever a medically necessary reason to do that?
Maybe, I mean, I don't want to say no, right? Because I'm not a
Mhm.
doctor, right? I'm not an OBGYN. So I don't want to say
Yeah.
there's never a reason why you might do it. But I think with a lot of these interventions, they get used very casually,
Mhm.
right? Like they get jumped to very quickly. Like I actually had my membranes ruptured in my first labor and delivery, and I was not a high risk pregnancy. Like I was a textbook perfect pregnancy, right? Like no medical conditions, like everything was fine. I was just like 6 days over my due date, and my doctor's like, "Well, this is what we need to do." And I didn't know at the time that that was not really true, and that it introduces the risk of infection, and like it wasn't really necessary. But my doctor was
Absolutely.
just
And that was,
like,
yeah, that
"Yeah."
wasn't a trick question at all. I mean, is it like medically necessary? And you'll know. I mean, they'll even tell you. And some will say, oh, if you're 2 weeks past your due date, we need to really start labor. If you haven't started, we need to progress labor or speed it up. And so that's when AROM, or artificial rupture of membranes, is used. If the baby's in distress, if the mom's in distress, if there's just like, okay, we need to deliver. But you're absolutely right. It increases the risk of infection because now you're manually breaking the water. And usually they want you to deliver within so many hours or days. I mean, it's not like, oh, you can just go back home and wait until your body then takes over naturally. No, once you do that, you're staying in the hospital.
Yeah, I mean, the same's true for really Pitocin too, right? I mean, there are definitely use cases, right, where it's like we need to do this now, right? And that's something I talk about in my high risk pregnancy classes. There are some complications that are very high risk for mom and baby, and if they start going the wrong direction, right, there could be a real medical reason why you need to start labor sooner than the body might want to do it on its own. But those should be like specific reasons your doctor can explain to you for why
Absolutely.
you would need these interventions.
Right.
And it's questionable, like I think if there's a certain number of days past your due date when it's absolutely required that you do these things.
6 days does not fall within, I mean,
Yeah.
outside of 2 weeks. Like I have heard 2 weeks. Like if you're at 42 weeks, we want to start doing something. I have heard that. And still people are like kind of pushing back on that. And I'm just like, and I not say people, but even midwives and other birth providers, they will even question, is that a medically necessary reason? If baby is just taking a little bit longer, do we just give baby more time?
Well, I think the thing is too is your due date's really an estimate, right? Like we act like it's some written in stone thing, like your baby is definitely 40 weeks on this date, but really your due date is just counting forward from the day of your last period. So, did you get pregnant on the day of your last period, like that day? No, probably not, right? But that's what it is, right? So it's really 40 weeks from the day of your last period is your due date.
Mhm.
But if you didn't get pregnant on that day, then that's not actually the true gestational age of your baby. It's just our best estimate. Or sometimes the doctor
Exactly.
will like look at the baby on your first ultrasound and say, well, it looks like it's developed enough that it's probably in this range of weeks here, and then like redo your due date based on that. But it's still an estimate, like based on your doctor, like eyeballing your baby on an ultrasound. So, I mean, I'm not opposed to like other providers like midwives or doulas or something being like, well, I mean, who's to say you're really 42 weeks and not 41, right?
So
Or,
true. Yeah.
and so if there aren't any like real concerning things going on, right, that would make us think we should probably, and mom is still feeling okay and comfortable. I mean, there
Yeah.
can be some flexibility there depending on what the mom wants to do, I think. But I
That's
feel like,
such a good point.
a lot of these interventions, like a lot of times, and this doesn't just happen in L&D, right? In the medical system, right? It takes kind of this paternalistic view, right? Where it's not treated as a collaborative process where things
Doesn't
are
that,
told to you
but
like they're
Erin,
collaborative.
doesn't that photo look collaborative?
I mean, they all look very happy.
They're so happy. I mean, honestly, like it looks like the parents were involved in their decision making. Last but not least, episiotomy and cesarean section. Reason why I included these is that if you had a C-section, most likely you're already being scheduled for the next one. Is that
Yes.
necessary? Is it appropriate? Is it indicated? Is it reasonable? Is it necessary?
I mean, not necessarily. I mean, you can do a VBAC, right? A vaginal birth after a cesarean.
Do you know
Um,
some hospitals, like, I mean, can
and
just
some
totally
OBs,
yeah, like
yeah.
totally opt out?
Yeah. And I mean, and that again, that's like erring towards it's just like the fall risk programs, right? Like we're erring on the side of not wanting any adverse outcome or at all, even if it's a small chance of it happening. I mean, the reason that you're told that you need to have C-sections in the future if you have once you have your first one is because there's a concern that you could have a uterine rupture at the place of that scar tissue um, for the cesarean. But again, that's something that's based on like a theory, right? Like and yes, there are some people that has happened to, but it's not like there's like RCTs or these large population-wide studies that are showing that people who have VBACs have a much, much higher chance of having a uterine rupture. They do, my understanding is like the percentages increase, but it's not like hugely increased. And especially if you don't have other risk factors, right, that could lead to a uterine or a placental problem. You could
Agree.
definitely
Yeah, uterine
potentially
rupture is
do a
what
VBAC.
it's less than 1%,
Yeah, it's
Erin.
not like it's happening
Yeah,
all the time,
no.
right? So, and a C-section comes with risks, right? So, I mean, I would be interested, like, well, what is your rate of like post-op hemorrhage or intraoperative hemorrhage or bladder injury or, you know, infection rates after C-sections compared to your rates of uterine rupture after VBAC? Like, are the percentages for those risks with C-section higher than the rate of the uterine rupture risk?
So much higher. What?
Right?
Yeah.
Because that makes it seem like maybe, while yes, a VBAC may come with a risk that a vaginal delivery who's never had a cesarean might not have, it could still be less risk than a C-section is to you, potentially. And some doctors have a limit on the number of C-sections they will do on one person. I want to say it's like 5 or 6,
Yeah. I saw a woman
maybe.
after, yeah, her number six. Number six.
So,
Yeah, and then
which
she had
I
a
mean,
hysterectomy at that time. And that was
if
only because the doctor was like, you're not having any more babies, and we're going to make sure of that.
yeah. So I mean, if you want, if you know you want a larger family and you want to have more than that, that's something to consider when you're thinking about cesarean versus VBAC for future deliveries after you have a C-section. Is if you do want more than whatever your doctor's limit is, maybe you should find a provider that could do a VBAC for
Wow.
you. Because they're just concerned that there's so much scarring to the uterus after 6 abdominal surgeries, right? That
Oh, sure.
and every time, and this is something in my high risk pregnancy class, right? That you're more likely to have placental problems, right? Like placental abruptions, right? And placenta previas, right? And placenta accreta if you have uterine scarring.
That's a
From some.
huge risk factor. Absolutely. Placenta accreta spectrum,
Mhm.
more likely to lead to a cesarean hysterectomy or a need for one when you've had uterine scarring. So happy that you are dropping some nuggets from your course. That's
Yeah.
why I wanted you
Mhm.
on. And
And
that's why I wanted to let you
yeah.
almost kind of have a dialogue with me about what your thoughts are on this. This is all from this article. So, same article. considered outdated if I were to present this at a national conference. It's 10 years old. So we're going to just go through how old this information is, how
Oh my God.
outdated.
But you know what's
Um,
crazy?
yeah.
You're not going to find some amazing like RCT of any number of years old saying that episiotomies are better than natural tearing. And yet that's like it has been standard of care for a really long time. Now ACOG has like updated their guidelines on that like it should only be done if it's like really medically necessary. But you know there's OBs out there still doing it. And they did it for decades with no like 10-year-old article or
No, it's
anything.
true. Oh, it's true. I mean, even if we even go the route of only using FDA approved medications, misoprostol is still not FDA approved for induction. Misoprostol, Cytotec, it's a very common pill,
Mm-hmm.
oral medication that's actually used for like three different things: induction to stop postpartum hemorrhage, and
Mm-hmm.
the FDA approved use is actually gastric ulcers. They found out by accident that it also terminates labor. So it's also used for abortions. But the three out of the four uses of misoprostol or Cytotec are completely not FDA approved, but that doesn't stop OBGYNs from using that. So I'm not
Yeah.
like bashing OBGYNs. They have reasonable, necessary, medically used purposes for that drug. And so when we think about like RCTs and evidence-based practice, it's like, hold on, we still don't have the FDA saying, yay, let's use this to induce labor, but we're still doing it. And
Yeah.
so
I
this
think
is just, I mean, when therapists, the whole premise of this whole discussion tonight is when therapists are told, occupational and physical therapists are told, your services are not necessary in the hospital after birth or even during labor and delivery. Let's really define what interventions are necessary. Let's define the whole thing. Let's define all of labor and delivery, right? Because when you push back like that, the conversation really rips the band-aid off of any scab that's been kind of like not allowing this wound to fester or heal. It's a festering wound when we talk about maternal health care. It's a festering wound. And so let's talk about this old, outdated information. 5 labor practices to facilitate normal physiology. Normal physiology of what? Normal physiology of birth, of delivery. Letting labor start on its own. So that means not giving Cytotec or misoprostol. Freedom of
Mhm.
movement. So that means not con continuously monitoring the baby with electronic fetal monitoring. That means not using an epidural, especially if they're under 5 centimeters dilated, right? They're not close to that mid dilation point. Should they be moving? Should labor support be given to reduce pain and to give emotional support and encouragement? Spontaneous pushing in upright positions. If they're on their back and their sacrum is fixed,
Mhm.
you're narrowing the birth canal for that baby to go through, for that baby to be delivered, for them to, like a cork, kind of twist their way out and allow the mom to twist her body at the same time. If you have an epidural, there's going to be less freedom of movement. And then keeping mother and baby together. I remember the first birth that I attended in the hospital, Erin, there was no golden hour.
Mhm.
I think there was maybe 30 minutes, maybe, where mom and baby were like skin to skin. And then all of a sudden baby was on the scale being weighed, doing all the checks. I was like, where's the golden hour?
Mhm.
What happened to that? And so
Yeah.
what's necessary? So I want to kind of get some ideas from you from a PT, OT standpoint before I go to this. Like, what justifies a rehab evaluation? What do you think about this list? Instead, going back, 5 labor practices to facilitate normal physiology. We know that's not being done.
Mhm.
5 reasons to offer a non-invasive rehab evaluation in the hospital. Let's go to afterbirth. Would you agree with this list and would you add anything to it?
Yeah, I mean, I think these are all good reasons to see somebody. Though I would even say like number 4 and number 5, those are things that you would need the evaluation to figure out they exist.
Need the evaluation. Ooh.
right? Like you're not going to know they have abnormal vitals with activity probably unless a therapist sees them most likely, or you add something else to postpartum nursing's plate, right? Which most nurses aren't going to, they're already busy, right? They're already understaffed, their ratios are too high, right? So, and then the social determinants of health that could lead to risk of complications. I mean, those are things PT and OT are asking about, right? So I would think you'd even need the evaluation to know those problems even exist, which is a reason to have the evaluation, right? To determine that they have abnormal vital signs or significant social determinants of health that could put them at risk for a complication, right? Um,
I totally agree. I mean, abnormal postpartum vital signs, we know that nurses typically are strapped. They're seeing couplets. So they're responsible for mom and baby. And so you would have to ask, or someone would have had to ask, case manager, social worker, Mom, do you have stairs at home? Mom, do you live in a third story walk up? Where are the stairs in relation to where your car is going to be parked? Would you have to walk around the corner like I used to when I lived in an apartment to get to the stairs and get to my second level apartment? Do you have help? Do you have social support? What kind of vehicle is going to pick you up? I actually interviewed someone, Erin, last month or so, TEDx speaker, international speaker that went home in this car that was like low to the ground after her C-section. And she was back in the emergency room within a week of delivery, right? Princess Castleberry. She was like, just told her birth story, all of it. Social determinants of health. Those could be a number of things. We have to evaluate to determine if there is a benefit to our services. So the evaluation is actually not the thing that we're fighting for, it's the interventions, it's the actual treatment. And so the way to justify that is to evaluate. You can't be told, oh, you need to prove your value in order for us to allow you to evaluate this patient. That doesn't make any sense. If they had an unplanned surgical birth, like a C-section, a major open abdominal surgery, got to evaluate them to determine if
mhm.
there's justification for your treatment. So we're on the same page to that. I bet you could probably add more to that list, but I kept it at 5. So I heard from someone, Erin, maternal health is improving. The deaths are going down. So this is actually from 2021 in blue to 2022. This was just published in May of this year. So we're about 2 years behind because of COVID. And so these are the stats from 2022. Deaths are going down significantly. Maternal health is improving, right?
I mean, deaths are going down,
The
which is
deaths are going down.
which is one component of maternal health. I mean, it is very important, right? Like being alive is super important part of being healthy, right?
Correct.
So yeah, it's really good deaths are going down, right?
I'm so glad you said that because I
Like
don't think that you
like
you totally agree with the World Health. They said ending preventable maternal deaths must remain at the top of the global agenda, but at the same time, simply surviving pregnancy and childbirth can never be the marker of successful maternal health care. This literally, that's what your reaction just reminded me of.
yes. Wait, so those were like global numbers or were those just the US?
Just the US.
Just US.
So
Okay.
this is the CDC. I follow her like
Okay.
a hawk. I'm always waiting for Hoyer to publish this data. It's always around the spring of every year. And
Mhm.
she was kind of a year ahead, COVID basically. We didn't have anything for 2020 until 2022. Then 2023, we had 2021. 2024, we have 2022. So we're now 2 years behind. But this so far looks a lot better than it did for 2021. I
Which is
mean,
good, right? Like
yeah.
I don't think PTs are saying that like or OTs are saying like we're the only ones that can like save people here, right? We're saying we're a component of a team that can get these numbers even lower, but that doesn't mean there's not things that other parts of the team can do as well to improve the numbers.
Absolutely. And that's where I say maternal morbidity, right, is also a marker of maternal health. And that's the short and long-term complications that may be resulting in injury, debility, mental health issues, things that moms are living with now, chronic conditions, pain, heart or cardiac conditions, kidney function, things like that as a result of pregnancy and delivery. What are they now living with? And now how are they able to live life? So that's,
Mhm.
hey, financial support, medical bills, maternity leave, housing, transportation, access and walkability to parks and playgrounds, their vocational training, their language, their literacy, their higher education, their food security. Those are all those things. And so if we're only using death as a marker, that's not good enough. It's
Mhm.
not good enough. And from a labor delivery postpartum care standpoint, I bet the people that are going to see this later, Erin, they're not going to be able to see my title, unfortunately, just on the recording. But it says labor delivery postpartum care team. We're part of that. And this team is a lot bigger, actually, than this list. I don't know if you would add anyone to it.
I'd add a case manager. I really think case managers should be coming to see all postpartum moms. But like at the hospitals I've worked at, there's not even a dedicated postpartum case manager. There's someone on another unit who just floats over if there's like some dire need, right, for some kind of services. But I mean, a lot of those social determinants of health, those are things case managers and social workers screen people for, right, and could help connect them with community resources. So I think they should be seeing them just like we should to help.
Agreed.
Mhm.
If there was some one thing that you could wrap this up for therapists, right, who just don't know, like they just don't know what they would be doing
Mhm.
in the room. And so when a physician says something like that to them, your services are unnecessary, really are not needed. They are fraudulent billing. We believe that you'd be committing fraud.
That's just crazy, right? That you would, I can't even imagine saying that to somebody, right? That, right? That you're committing fraud by evaluating someone for your services alone. But
Evaluating, I mean, that's the thing. Like,
right,
how do
like,
you say that you're committing fraud by just wanting to check in?
yeah, like I'm just evaluating somebody, which is something I bill for. Like I'm going to bill for the evaluation,
Of
right?
course.
But like it's like they're acting like my services are so obviously unnecessary that even the evaluation is unneeded. Like it would be like if you have a mom who, speaks English and I charge her for, I don't know, a German language interpreter, right? Like it's so clearly unnecessary that it's obviously fraud. Like they're acting like it fits into that category,
Yeah.
right? So obvious.
I read a web PT blog on this where it's like when you are committing fraud, you know you're committing medical fraud. Like you know it. Like there's no doubt about it. You're intentionally doing something that you know is going to overbill, overcharge the patient, and you know it's unnecessary and you're going to do it anyway. And so when that kind of language is used, that's when I'm like, let's rip the Band-Aid off of everything. Let's pull the curtains back. Let's see what's going on.
Yeah, like I've never actually had an OB say that to me. But
But therapists have.
yeah, which is crazy. Um,
Okay.
it's
So if
crazy
you're
to probably say that to you, but I feel like I don't know, I feel like from an OB perspective, like you should be able to talk to them about like birth is one of the most like monumental events the entire body goes through, right? I mean, if someone who medically manages that as an OBGYN, like you know that your specialty is monitoring one of the biggest events in somebody's life, not only emotionally, but also physically, right? That it changes
Yes.
every single body system, right? Like I feel like there are OBs who would be receptive to that, right? Like you're kind of stroking their ego, right? Like your specialty manages a whole body system wide thing, right? That changes every single organ system. It doesn't just magically all go back after birth, right? It can have effects that can last for years. And your patients deserve to have somebody come in who specializes in making sure that they will be able to meet the functional demands that they're going to have at home in ways that are safe, in ways that factor in things like how much blood they lost, that screens their vitals for some of the most common complications postpartum, right? Because we don't want them to go home and to decompensate at home or to start developing symptoms of a cardiomyopathy when they're on the stairs with their baby, or because they Googled how to get my body back after baby and started doing a, half marathon training program at 3 days postpartum. because they didn't know, right? That's something that therapists can help them with, is knowing how to safely return to exercise and how to be able to do just their minimum daily activity in ways that are safe and that protect their tissues that are vulnerable, like their pelvic floor or their C-section incision. I mean, there's so much that we could offer patients.
Absolutely. There's
Yeah,
have you run across Dr. Sabina Khan? She's an occupational therapist that
yeah,
actually
I know
really,
who she is.
oh my gosh, like what she's doing with teen moms, I'm thinking like in function. I think in function terms. I'm a physical therapist. I think very biomechanical. When she gets into occupational impairments, talk about a young mom who's still trying to navigate school
Yeah.
or wants to go to college or has to now navigate this world and a newborn. Like for me, I think the problem that I'm kind of coming to terms with now is how do I help therapists think on the spot?
Hmm.
Because that's where it comes down to. Because like once you start talking to them, they're going to be like, "Oh yeah," and then they want to go and run back and fight, and it's like, "Wait a second, let's think through this, and how do you justify your services right then and there? How do you come up with that
I
justification?"
feel so I feel like, and this is a good way to buy yourself time also. If you're like, someone says something shocking to you, like you're committing fraud, and you're like, what? And your brain like explodes a little, right? Is to ask them a question.
Ooh, what do you
Like,
mean?
right? Like if they're like, well, I think this would be fraudulent to bill for this, right? Be like, can you explain that a little bit more? Like, what do you see being like, where would we be crossing the line into fraud? Right? Like have them explain themselves a little more. And that also buys you some time to like think about it a little bit, right?
Oh, Dr. Locati, that is brilliant. Okay.
Right.
Okay.
Ask them, and also people like to talk, right? They like to explain themselves, right? So asking them some curious questions about like, could you say a little bit more about that? Could you explain that a little bit more to me? I never thought of it as being something that could be fraudulent, but I mean, I certainly wouldn't want to commit fraud. Could you explain to me a little bit more? Like maybe there's something I'm missing here, right? And have them explain it to you. And that also gives you like, you know,
Oh, no, absolutely.
some
Tell me a little
time
bit. Yeah.
to think about it. I mean, I don't know what like I mean, I guess what they would say, like we need to talk to someone who's had somebody say this to them, right? Like what do has anyone had a doctor explain to them more why they think it's fraud beyond just saying it's fraud and then you're like, oh shit, and you like walk away.
It's true.
Um,
Yeah.
because I assume the reason why they would think it is fraudulent is because it's so obviously unnecessary to see somebody um in the hospital. So, I mean, I feel like I would want to ask them like, well, what is your understanding of what PT or OT does with patients in the hospital or does with postpartum patients specifically? Because they're probably thinking of like someone like, I don't know, after a knee replacement where you're like helping them get out of bed and go
That's
up and
exactly what's
stairs
happening.
because they're physically going to fall if you don't teach them how to do it. And they're like, these patients are walkie-talkies. They can just get up and go.
Oh
So they
God, I hate that
need
term.
your services. I know. So, so they don't need your
Walkie
services.
talkie, I hate that term. You just like, "Ugh." I want to end with this because this is Dr. Karen Fox, who actually was the first OB/GYN that I met, who automatically ordered physical therapy in the hospital after birth, cesarean hysterectomy to start, C-section later on. What she said was there is a lot of bias. There's a lot of bias in pregnancy and postpartum care on comparing a young mom who might be walking around with hypertension, postpartum preeclampsia, waiting to blow up, cesarean section, risk infection issues, things like that, sepsis. She said there's so much bias that we're already determining that this person wouldn't benefit from PT. She's like, there's actually a benefit to other providers and to our patients to have PT and OT on the team and nutrition. I mean, she went on and she was like listing all of us allied health professionals. And this is a surgeon, maternal fetal medicine specialist. And so I want to end with this, Erin, because you teach acute care therapists specifically, but you also branch out your training to I'm going to guess therapists in other settings, right? So that they can be aware of what are these just introductory skills that we should really honestly be preparing our grad students with
Yeah, it
in
should be in
OT and PT?
PT and OT programs, right?
Yeah,
Like
I
the
want
content
you to
I
be
cover
in
in my
PT.
classes,
I
like my
seriously want you to
classes
be
should be part of
traveling.
the curriculum. They should be like,
Seriously, I want you to be a part of OT and PT curriculum somehow, whether it's even just a course that like I would hate to be an elective, but it should be some part of either cardiopulmonary. There's just so much that you cover in your courses that doesn't fall under pelvic health, falls under so many different areas, right? In the curriculum of just learning about the human body. Birth, maternal health is a part of that. And so what can you say like for therapists who are like, wow, I've never even heard of this before. Where do I start? Where should they start in terms of getting just education about this?
I think you can hear my kids yelling in the
They're like,
background.
my mom's intro to PT and OT course, high risk pregnancy. That's why I would be yelling. Like, yeah, talk about your courses and what you're training therapists to do.
So both of my classes, I have an introduction to postpartum acute care therapy, which is really like a super early postpartum care class, right? Like kind of the 0 to 6 week time frame, starting in the hospital after you've delivered before you discharge home. And then I have a high risk pregnancy course, which is focused on providing PT and OT care to people who have common complications, especially ones that where they're often prescribed activity limitations, so that you can learn what you could safely do for this population, because there's actually a lot that you can do for them. So, okay, it's getting louder. My kids are getting louder.
They're like,
So,
yeah, mom.
I
No, I
know.
love this. This is awesome. So you have those two courses
This is
and
right here.
anyone can get like there's no prerequisites. Anyone can
Nope,
get
I mean, so
started.
anyone can sign up and take them. Right now they're available on demand. So you can go to the Pelvic Health Network under my courses page for Erin Locati, and you can just watch them. They're recorded. They're both 5 hours long. You can get CUs for them if you're a physical therapist. So it could
In
be a good way to.
Texas too. Texas has like
Yeah,
reciprocity with everyone. They're
I
like
know. So
they're an amazing.
most states will accept CUs that have been approved in another state. So since they've been approved in Texas, most other states you can just submit like your certificate for whatever your procedure is in your state and still get your CEUs. But I really like these classes because I feel like I said, I think they should be part of PT school education. So they really start from a place of I'm someone who really doesn't know, like the intro class for postpartum starts from a place of I don't really know much of anything about pregnancy and postpartum, right? I know what most people know when they come out of PT and OT school, which is little to nothing. So it starts with assuming that's where you are, and let's make sure you understand kind of the basics of what's happening to all your different body systems, right? Your cardiopulmonary system, your renal system, right? Your pelvic floor, right? Your orthopedic system, more of the orthopedic changes that happen with pregnancy. Like, let's make sure you understand all these huge system-wide changes that are happening to the body during pregnancy and understand the timeline under which they resolve postpartum. And what's the implications of that? Like, if I'm going to see someone at 24 hours postpartum, which of those changes are still there? And how's that going to inform what I do with them? What are some of the common complications I should be watching out for? How do I design an early rehab program for someone to take home with them that's going to be safe and effective, even for somebody who is not going to have supervision at home from a therapist or a personal trainer that specializes in this? And then the high risk class is a little more advanced, right? We don't cover like all the basics of pregnancy stuff that we cover in the intro to postpartum course. We just jump like right into the different types of high risk pregnancies that somebody can have. So like placental abnormalities, a few different types, hypertensive disorders that can come up with pregnancy, preterm labor, like early labor conditions that can come up, like preterm rupture of membranes or cervical insufficiency. And we just walk through like physiologically what is happening with those things, with those different complications. And are there any implications for you as a therapist in terms of what you can do with them physically, in terms of like exercise or movement, but then also addressing kind of the mental health side and the coping side of dealing with having a high risk pregnancy. And especially if it's going to interfere with you working, taking care of the other kids, or even being able to stay outside of the hospital.
There's it sounds like a ton of benefits that we offer. Seriously. this population in the hospital.
I mean, it's just endless. Like, but one of the hardest parts of making these classes was figuring out how many interventions to put in there and how many to cut out because it's only a 5 hour class. Like,
For real.
right? Like,
Yeah.
like just the coping mechanism stuff in the high risk class. I was like, you got to cut like half of this out. It's too much. It's too much stuff. Like
Yeah.
for a class that's this length, right? There's just so much that we can offer these populations. Like,
Erin, this is a pitch right now. If there's anyone, if you are in a university and you're wanting to bring just a fresh perspective on underserved populations, actually, I hate that term, populations who are not being served. The maternal population, when it comes to rehabilitation and a priority on their recovery and their function and their the occupational demands, right, that impact their ability to thrive through their postpartum recovery, they are a population that's not being served by rehab therapists acutely. We're waiting until they develop those impairments. We're waiting to see them 6 weeks or later. And so if you are an educator in an OT or PT program, if you are one of our leaders in our therapy associations, our OT associations or PT associations in every single state on the national board, you want someone to bring this education to light. You want them to prepare your students, your entry-level therapists. I'm doing a pitch right now. Dr. Erin Locati, I absolutely 100% approve this message because I'm saying it, but I'm telling you, I've probably, there are not many therapists of this caliber, of this education and teaching caliber in the maternal health space. There are not many. And she's one of the very few that I have just the utmost respect for. And absolutely, like, please, definitely look into her courses, look into seeking her out as a speaker. I can't thank you enough, Erin, for joining me and just going through this exercise and really lighting a fire under me that there are still therapists who are encountering whether or not people are really benefiting from our services and whether an eval should even be offered. I hope this answers that question.
yes, this population's underserved because the system chooses not to serve them, right? And we could choose to do different, you know.
That was a mic drop. That was a mic drop. If I get an editor, I want the bombs to go off at that point. Thank you, Dr. Locati, for your time.